Everyone. Beautiful. Recording in progress. Hello, everyone, and welcome to what will be our last meeting of the Essential Support Workforce Advisory Committee. I'm Jess Maurer. I'm the Executive Director of the Maine Council on Aging and am the chair of the Workforce Advisory Committee. And I think we are going to start today with introductions. So I will turn things over to our vice chair, Catherine, to start things off.
Hey, thanks, Jess. I'm Catherine Thibodeau. I'm the Executive Director of Independence Advocates of Maine, and I am the vice chair of this committee and also representing IDD providers in this setting. And so I'll just call on the next person in my line, Kim.
As an early attendee, hi, I'm Kim Moore. I'm the director for the Bureau of Employment Services, Maine Department of Labor. Pleasure to see you guys. I'm going to say Betsy's probably next.
Good afternoon. I'm Betsy Sawyer-Manter. I'm the CEO at Seniors Plus. I'm here as a representative of the service coordination agencies in Maine.
And how about Representative Margaret Craven?
Well, thank you. I am Representative Margaret Craven, and I am here as appointed by the speaker. Thank you.
Great. Abby?
Hi, everyone. I am Abby Stivers. I'm the Director of Workforce Initiatives for the Office of Aging and Disability Services with the Department of Health and Human Services. Karen?
Good afternoon, everyone. Karen Mason, Associate Director at the Office of Aging and Disability Services, and I oversee the Healthy Aging Services and the Long-Term Supports and Services programs.
And how about Don?
Hello, I'm Don Dufour, the Chief HR Officer at Tri-County Mental Health Services, representing the behavioral health services sector.
And how about Michael, who's in Witness Protection Program?
I know you like my background here. It is way too bright. So yes, Michael Smith with Catholic Charities Maine for this group serving as the ISS Independent Support Services and the Homemaker Program.
Terrific. Now I've lost my Zoom. Gloria.
Good afternoon. I'm Gloria Noyes, and I'm the Assistant Director at Westbrook Regional Vocational Center, and I'm representing career and technical education and our future trades folks in the state of Maine.
Thank you. And then we've got a couple of guests. Sarah, do you want to introduce yourself?
Do I turn this on or just talk?
Can everyone hear Sarah okay now?
Hi, can you hear me?
Yeah, from in the room, yeah.
Okay, I'm just trying to figure out if I'm using my computer speaker or not. I'm Sarah Griffen. I'm a consultant to the Department of Health and Human Services and DOL, focused on some benefit cliff work that I will be talking to you about.
Great. And then we also have Karen Lee Harrington here.
Good afternoon, everybody. Karen Lee Harrington with the Maine Health Data Organization and the Maine Quality Forum. And I am here just in case you have questions, I think, for later in your conversation.
Great. Thanks, Karen Lee. And we have a couple of wonderful staff folks who are helping the advisory council who are, I think, in the room at DOL. Angelina, do you want to start?
Hi, everyone. I'm Angelina Clufus-Jean. I serve as the Director of Strategy and Innovation for the Bureau of Employment Services, and not feeling very strategic or innovative today with the tech fails, but if anything on your end tech goes wrong, please feel free to chat me and I'm happy to be a problem solver for you. That is true for audience members as well.
And hey, everybody, I'm Dylan Murray. I'm the Legislative Liaison for the Maine Department of Labor. Excited to be here.
Perfect. Anybody else in the room at DOL or anybody else we've missed?
Nobody on the DOL side.
And the room is just the three of us. That's a three-person party over here today.
Beautiful, beautiful. Well, sorry we couldn't be there in person, but you know how things conspire against you. So, well, and I think it's always important to remember we've got some other members who are not able to be here with us today. And I also just like to spend a couple of minutes reminding folks what we're here to do. So I'm going to just review our duties and powers quickly. One is to collaborate with the Department of Labor, Department of Health and Human Services, the state's institutions of higher education, state adult ed programs, career technical centers, regions, and others and make recommendations. We're supposed to collaborate with those folks, make recommendations to state agencies and the legislature related to recruitment and retention of essential support workers, monitor essential support worker shortages and the expansion of essential support workforce to examine if actions taken to promote expansion of this essential support workforce have been successful, make recommendations to the Department of Labor, Health and Human Services, the legislature, and other agencies regarding additional research needed to further the expansion of the essential support workforce. I'm going to put a little pin in that because we're going to be talking about that later. Collect data related to the essential support workforce, examine benefit cliff effects on essential support workers, and recommend develop the pilot program to mitigate benefit cliff effects on essential support workers, and make recommendations to the legislature, including any suggested legislation. Of note, that legislation can be reported out from this advisory council. So any questions there before we move on to checking in? All right. So I think the first part, unless I'm wrong, Angelina, I am working on the last agenda I have. We're going to start with committee member updates. Is that correct?
If that's okay, and that'll give us
Yeah.
some time. We have another guest coming.
Yeah, that's perfect. Yep, that's perfect. So we're going to start with committee member updates just for everybody, because we also have some listeners at home. So and welcome to those folks too. We are going to hear from committee members and related to updates specifically related to the essential care and support workforce. And then there'll be a public comment period. After that, we're then going to have a benefits cliff presentation by Sarah Griffen, and we'll be joined by Chris Hasted as well during that presentation. Really one of the few experts in Maine on some of these issues, so that we can ask her some questions about her prior thoughts on this topic. We'll have another period of public comment, and then finally we'll have a conversation. We'll report out, myself and some others here will report out on some conversations we've had with the Maine Health Data Organization, and talk through some recommendations we have for the committee. And then again, we'll have a period of public comment at the end of that section. So we'll start now with committee member updates. Who would like to go first?
Hi, very cheeky here. I don't have anything prepared except that we are still, as a delegation from Lewiston, actually, I haven't been talking to other legislators outside of Lewiston, but just having massive concerns about the lack of staffing in mental health, for mental health providers especially, but also for DD and ID workers, and of course hospital workers. We just had a meeting with yesterday or the day before with Central Maine Medical Center, and they're down something like 800 workers, and that just seems. But also having concerns about resources coming to them, especially in the mental health sector. I think maybe the department is working on trying to work something out with that, but it is, especially being from Lewiston at this particular time, it is very, 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 very worrisome that we may not have enough mental health workers to care for our citizens. Thanks.
Just show mute.
Well, that's good. Good thing, because I called her Margaret, and then I said, "Oh, Senator Craven." I mean, Representative Craven. See, now I go Senator Craven.
Well, I am a Margaret, actually.
You are a Margaret, yeah, and you were Margaret to me before you were any of those other things. So, but anyway, thank you very much for that comment and reminder. And I know, Donald, you're in Tri-County Mental Health, and how are things there, particularly related to staffing? If you might share some updates.
Sure. We've continued to be challenged with staffing, probably more so not from an ability to bring them in as much as it is to retain them. And we're still trying to figure out, is it something we're doing up front that we're not educating candidates enough to the role? But understand the role is not what the role was even 2 or 3 years ago. All of these positions, and especially entry level mental health positions, have been dealing with a client population that has certainly become more acute and is facing a significant shortage of resources to support them. So that's really it's been a peak and valley ride for sure. We are not where we'd like to be from a staffing position. So that means we continue to grow wait lists for our programs. And as we have been able to move members on that wait list, we're finding, often they're not able to sustain staying on a wait list. So they have migrated to other wait lists just in an effort to really get the first open door. So that continues. We've really tried to focus on growing our own, so offering training and resources to existing staff so they can assume positions that are not only entry-level mental health positions, but positions of greater responsibility and theoretically greater resource to our clients. But yeah, still very challenging. This labor market, I've been in human resources for decades at this point, and I've not seen a labor market like this ever. The competition, even amongst like industry, is really difficult. And we're all in this for the same reason. We're all trying to support the same folks within our communities, but the workers are simply not there. There's a lot of appeal from positions outside of our industry, and for some, it's a life choice. It's a life decision when they can make significantly more in some cases doing work that they may not love, but it keeps the lights on and puts food on the table and gives them a higher standard of living. Those are the choices people are making. Now, there's some hope at some point that turns around and they come back to their passion. But in the interim, we're still struggling, I have to say.
Yeah, I live in Harpswell, but I have to go through Brunswick all the time. 1875 is what the starting rate is now at Burger King.
Yeah,
so,
I hear it all the time.
yeah, it's rough. And I'm going to ask you one more question, just since we're heading into this conversation around the benefits cliff. And I know I've heard this from other provider types, and I don't know the answer from you. Do you have staff typically, or some staff that are recipients of public benefits, if you know? And do you know if well, let me just ask you that.
We do have staff that are recipients of public benefits, and we also have staff who now are losing public benefits and being forced to come back on our benefits, which certainly is going to be a further deduction from paychecks. But it is something we're continuing to try and work out. I mean, we do this every year. We put all of our benefits out to bid. We look to see what is the most viable resource that will still serve what employees need, without taking a third of their paycheck, particularly for entry level positions. And that's a challenge.
Thank you.
And if I could jump in, I think the last committee, if I'm understanding correctly, the last committee meeting, folks were asking about universal credentialing. Is that correct, Jess?
Yes.
Okay.
Yep.
Again, I don't want to jump over the conversation about the benefits cliff at all, because but I know that someone's coming in to talk about that. But in terms of just strategizing and, again, we all know that workforce is a huge challenge right now. And part of what the department is working on, and we've been working on it on and off for a while. I think Representative Craven, you were probably on HHS a while back when our director, Paul Saucier, brought forth the concept of really streamlining the credentialing. Now, I will say that the concept of universal credentialing is really bringing all of the service delivery systems in terms of credentialing into one training. However, to date, that is not something that we're pursuing at the moment. We're doing more of a phased approach, and Abby, who's on the call today, has some more details about that she can share in just a moment. But we did look into what a pure universal credentialing could look like. And at this point, we've looked at other states, we've talked to other subject matter experts, and that is something that is very, very challenging to do, as you can imagine, because there are different skill sets depending on the service population that you're working with. So we did have conversations with behavioral health services and the Office of Child and Family Services to sort of see how we could potentially weave a universal credential in to this current process, which is looking at our personal support specialist credentialing, which mainly works with folks older adult population, and then looking at our direct support professional credentials, and that credentialing typically works with adults with intellectual disabilities and autism, and how we could create a base credential so that if I wanted to work with older adults, maybe for a year, and then maybe work with older adults or adults with intellectual disabilities and autism, today I have to take two separate training processes, right? Two separate credentialing. And the goal of this project is to streamline that. So I could take one training and I could start working with either one of those service populations today without having the burden of taking on another credentialing. The cost, the time, we all know can really deter people from moving across those systems. So our first phase is really to streamline those two credentials with an eye toward working with the Office of Behavioral Health and Child and Family Services. And I think there were some potential questions about what Office of Behavioral Health and Child and Family Services are currently doing, because there are a lot of different initiatives going on. So with that, if I can turn it over to Abby, she can give you some more details and help walk us through the different types of initiatives that are happening in order to really help streamline the credentialing part of this direct support workforce in order to really help with that workforce. Abby?
Can I
Interrupt first, just because I wanted to add one little line.
Sure.
Thank you.
Margaret, can you hang on for 1 second? Representative Craven, just because Catherine, did you have a question for Karen?
Oh, sorry, Catherine, I didn't see your hand up.
Okay, she had her hand up since for a while, so I just wanted to.
I wanted to go back to what Representative Craven, I wanted to sit on that for a hot minute before we move to the benefit cliff, if we can. And I'm just curious from, anybody who's a state representative, representing ODES or DOL, have the events that happened in Lewiston and the subsequent obvious critical behavioral health needs of that community, along with the apparent lack of access to behavioral health services for the individual, has that moved any needle? Has that moved any needle in the workforce discussion? Is that has that done anything to change strategies or is there anything going to be introduced in the next session related to this? I mean, if we didn't need something that hit us over the head of what happens when you don't have an adequate behavioral health system and workforce, we have a crisis going on in our state and we don't have the workers to help the people that have been traumatized. And so I just want to sit on that can we just sit in that space for a minute? And I'm just curious, Karen, Abby, Angelina, anyone that is there something going on, any movement? And that was what I had for a question.
So, Catherine, that's a great question. I would say I can bring that question back to folks because, of course, we don't work directly for behavioral health services, but we can certainly bring that back to folks who could potentially assist with that. I do know that we are in the process of setting up some listening sessions for providers over in that area, the affected area in the Lewiston area, to hear from them about what the challenges have been. So those are happening in the next couple of weeks. But in terms of specifics related to anything that's coming up for legislation or directly related to the workforce, I am currently not aware of anything. I don't know if others on the call could assist with any of that information.
I'd have to echo the same, Karen. I know that we have offered some suggestions of how our existing programs or expanded services might be able to help, but I'm not aware of any kind of pending legislation or anything like that. But I am happy to follow up and see where that landed. It was coordinated through our governor or our commissioner's office.
And sorry to have interrupted you, Representative Craven, but do you have any thoughts on that? And then if not, you can certainly feel free.
Well, we have a resilience center that I know Tri-County and others are working there to be available for the families who are directly affected, but there's a lot more needed in the community. We have been working just a little bit with Director Squirrel to see how the department can support agencies that are really struggling with staffing and resources and things like that. But the reason that I was interrupting after Karen's presentation really was that we were at the University of Maine at Lewiston-Auburn College the other day, and they have launched a program for credentialing new Mainers. And working very hard. I mean, it's difficult, to find transcripts and all kinds of materials for people who've been living in refugee camps and that sort of thing for years. But I'm encouraged because they're trying to create a pathway for especially immigrants and new Mainers and others like that. So I think that'll be very useful, especially for DSPs and mental health workers and entry-level workers especially. So thanks.
Can I ask one question of you, Karen, before we move over to Abby? Did you specifically talk with folks in Michigan about their credentialing initiative?
So Abby will need to answer that.
Okay,
Jess.
sorry. Perfect.
I didn't specifically.
So great. Abby, did you?
I did. When we first started the idea of a universal credential in Maine, we had phone calls with folks in Michigan, Washington, California, Arizona, New York, Vermont. We tried to get anyone on the phone who would talk to us, and we were able to sort of round the wagons at 2 NGA consortiums on healthcare workforce that the department was able to attend this spring and summer, to talk about what all the states are doing. So what we came up with and what we are doing is sort of a reflection of those conversations, and also what we've learned from our stakeholder groups, which were assembled when Muskie was part of the project, when I came right on at the start. So I can pull up my PowerPoint and I can walk through some of the decisions and what Maine's making and what we're in the process of for the direct service worker course, which is the universal sorry, you're right. That was a bad turn of phrase. We were able to convene together and share our ideas about what we were doing. So let me just share my screen here.
What is the initiative called now that it's not called Universal Worker? Does it have a new name?
Does. Just trying to make sure that I can see you and my presentation to make sure that if any hands are raised. So we are calling it a direct service worker course. That would be the name. The progress, we undertook a survey of nationally available curriculum and best practice standards to figure out what was out there in the field. The same year, we worked with Muskie to assess all the HCBS training across the state. And then we started working on the course in 2022. Some of the things that came up about that universal credential title, and I know that we have a jam-packed agenda, so I'm going to try to go through this quickly. If there's any questions, happy to answer those. There is a lot of subject matter expert feedback that is pushing back against the idea of a universal credential, mostly because pillars of training have already been created for our various service populations, aging folks, the IDD community, specific interests and issues for mental health and children. And so pulling all of that together is receiving a lot of pushback from a lot of stakeholders in other states. And there aren't big university systems that are working on it. Big providers that we could have bought our curriculum from directly are Elsevier, Relias, companies like that. And they are keeping that training siloed and not working towards a universal credential. So something we have to create ourselves. We also chose to create this ourselves, this DSW course, because when you buy curriculum from national providers, there has not been a big momentum in getting that information into other languages. It's not there. And this is something that all of the states have sort of chatted about. I've had multiple conversations where we, as people pushing this work forward, don't really understand why educational companies and people who make this curriculum for profit are not putting this into other languages, but there isn't really a push to do that. And Maine really wants to make sure that what we have and what we create for training can be really accessible.
And Abby, if I can just interject, I think this goes back to what you were talking about, Representative Craven, with the training that you are aware of. This really, really stands out as something that when we move forward with this, it is a must that we offer this in other languages, as well as for the deaf and hard of hearing community. So that's, again, as Abby said, another reason why we're creating this, so that we can ensure that as many people who want to be in this field are supported and able to be successful in their credentialing.
Thanks, Karen. Absolutely. And so we started with conversations with OCFS and OBH, who were unavailable at the time when we started this work. They did not have the bandwidth to join us in this. However, creating a first step of combining aging and IDD training is really going to create a base set of credentials. So what we're working on is a direct service worker course. That title was specifically chosen because there are a whole bunch of national groups trying to make sure that we understand on a national level what a direct service worker, a direct care worker, a direct support worker, all of those titles that we've heard that are sort of all over the country, they're trying to stabilize those and make sure that we have wage data on them going forward. So we wanted to pick a title for the course that would be captured by federal data going forward. The course is going to be 50 to 55 hours of instruction, including 8 hours of in-person instruction. It's going to create stronger training for aging populations as part of that skills checklist that we're working on. It's going to update that aging training and provide aging training as the base level for DSPs going forward. One note about that, we are not replacing the title DSP because that is a national title. DSW will be the first step in this credentialing process, and then DSP will be the second. But DSW workers will hit the ground running and be ready to work with aging or ID service populations when they get going. And then, Jess, I know you're super interested in other states and you're working with directly with one of the researchers at PHI. So I wanted to chat a little bit about how what we are creating stacks up with some of the other states. So for Wisconsin, they created a 30-hour of instruction, 14 core competencies, and gave bonuses to people who got through that course. We did not want to create something that was quite that compact because Maine stakeholders, the training community, those who receive services have told us in Muskie stakeholder meetings, I think, Karen, there were 3 of them when we held them, that the in-person training component was really important to talk through issues that folks were having, to make sure that they had the skills necessary to go into the field. So we wanted to make sure that we were keeping the training levels that we already have and building on them. Maine's had some really good training for a while, and so we wanted to make sure anything we created was an improvement, which is why ours is a little bit bigger. Michigan's doing similar stuff. They're creating 3 stackable levels of direct care worker education. We didn't necessarily want to call anything that we created care work, preferring the term support for some of our service populations. We also wanted to make sure, again, that we kept in line with that DSP credential, because nationally we heard from multiple subject matter experts across the globe, or across the United States, that was going to be a title that was going to get attention on the federal level, that people knew what that was. And so we wanted to keep that in our training paradigm. And then North Carolina is sort of where we were about a year or 2 years ago. They're crosswalking the curriculum that they already have. They are moving towards CMS core competencies, and they're working on their new curriculum. This is just a quick slide to explain the matrix of stackable versus portable credential. Portable meaning something that can go across multiple service populations. Right now, we're looking at increasing portability between aging and IDD services, and we'll branch out and chat with OBH and OCFS once we have something and see if they have the bandwidth at that point to work with us to increase that portability of the DSW course. And then stackable training, meaning that it's a level on a training rung. And when we have the course completed, we'll also start working with some of the providers across the state and the university system to see where and if we can, plug in the training that we've created specifically for our service populations into the career ladder of training and services. This one's sort of a similar, doesn't allow people to move back and forth. The goal of this is that it would. It'll provide a comprehensive overview of direct care and support work per CMS core competencies. CMS published a list of core competencies for home and community-based service workers in 2014. And every aging expert and IDD expert that we spoke to was very clear that this is going to be the national standard for any curriculum projects. So we've made sure to create that around that set of trainings. The assessments will be about what you learned in the course, and also that you can demonstrate what you learned. The course that we're creating is also around adult learner best practices. We're taking out a lot of the reading that folks told us in those same stakeholder groups that they did not like, and replacing it with more narration, adult learning games, and activities to sort of meet adult learners where they are, making sure our language levels are low, and making sure the graphics that we have are accessible to anyone who would want to take the course. And then we're also hoping to get this course translated into multiple languages for the various new Mainers that might benefit from having that in those languages, and any hard of hearing or deaf folks across the state. And then overall, the aging material is going to be updated to reflect the national best practices and create a strong foundation for our workers. I know I'm going way over time. These are the CMS core competencies, just to give you a list of some of the overviews of what CMS would like mandated in all of the trainings. So we have lessons and units that go over most of those, not most, all, sorry. Which creates a career pathway of core competencies that gives our core competencies here any additional mandated service population trainings. And then we can build on the trainings that would provide people with a raise in pay for additional work. And then the last thing I have is a marketing update. But before I spring to that, are there any questions or things that I can answer about this? Again, going kind of fast because of the schedule, but happy to answer anything about it.
Catherine, and then me.
So in this, 2 questions, I think. In this vision, who would be providing the training? Is it still done as a combination of some kind of state platform and live trainings done by providers, or is it something that people have to go to another location to get? What is the vision there?
The vision right now is the first part of what you said. So this training will be available online. The department will host the platform, and then the in-person training will need to be done by trainers. Once we have the course fully created and we can say it's 52 hours or something like that, we can move on to next steps of seeing how much the state can support training going into the future with the federal funds available. But I think there are some open questions. Karen, did I get the vision for that about right?
You did, yes. And Catherine, you're right. I mean, I think the goal is our platform. The platform we will be using will be the state's platform. So as we were rolling this out, the state of Maine was also in the process of an RFP for a platform. So what we did is we just did some discovery work, and along with some of the other departments, of course. And what we discovered is the platform that was purchased by the state can also be used for this type of training as well. And again, just to reiterate, the trainers, because I know right now there are in-person trainings, and through our stakeholder work, we brought the trainers to the table to have a discussion with us. And again, they were very clear that they truly believed, as well as other service providers, that some in-person training is really pertinent, and we should not go to a full online training. So we do believe that there will be some continued need for trainers. We haven't fleshed all of those details out yet, but those are the next steps.
Okay. And then I guess I'm going to have two more questions, but one is like, how, I don't know how to articulate it, so I'm just going to say it, but like, how are you guys, as you're going through this process, collaborating with other initiatives or other current things? So two things come to mind. One is the lifespan waiver in IDD services, which is going through this qualifications process of determining qualifications, and like we're in a cart, or whatever it is. We're in a situation where one's got to take the lead or the other's the work, So just how you guys are collaborating that work, and then just the myriad of Maine Care rules. I'm thinking more in IDD services of when an employee can begin to work. And so like how that's going. And then I'll just ask my other question. And then I heard you say, Abby, like stackable and more pay. So does that mean that there's going to be rate reimbursement modifications to support these stacks and this more pay? Is that being built into the system?
So Catherine, I think I can answer those. So the question about requirements in terms of Maine Care requirements, and all of us talking together, you are correct in that Maine Care is at the table as well as Betsy Hopkins, Associate Director for Developmental Services and Brain Injury. So we are all collaborating together in terms of what those next steps may be for the different service areas, if you will, as well as what will need to happen in terms of changes and modifications to Maine Care rule around requirements. Does that answer two of the three questions?
Yeah, lifespan waiver in there too.
Then,
so that
and then lifespan waiver. My sense is, are you asking about timing in terms of when the lifespan waiver will be rolled out versus what they're credentialing?
This is probably a really weedy question. So if it's too weedy, so I'm on a provider advisory group for the lifespan waiver where we're providing input on the qualifications for somebody to do all these different services in the lifespan, right? And so I'm confused by the qualifications. We haven't had a meeting about it yet, but if we set up all these qualifications that are sort of outside of the discussion of this direct service worker curriculum and the vision for stacking there, I think the vision for, so are those all working together? Is the vision for stacking in the lifespan waiver and the vision for stacking in the current section 21, and I'm only section 2129 of IDD services and the vision in this direct service worker curriculum all going to, is that all talking to one another? And is there a logical order of what's being decided first and how that's being done?
So I don't specifically have the details around lifespan waiver.
Mhm.
I think though, again, Betsy Hopkins is at the table with these conversations, and I'm wondering if the input that you are providing around qualifications might be qualifications for the service delivery versus
It is,
direct
but it
care
says what?
DSP qualifications to perform the work in someone's home or residentially. Does that make sense?
Yeah, it's really the, you know, performing this service, you need to be this credential and you need to have taken this course here and this course here and this course here to provide the service as a DS, I'm just going to use quote unquote DSP.
Yes. Okay.
So you know, I'd love to be able to like make that link, maybe if that linkage isn't, because it's in looking at that, what's been provided to us as draft and looking at this, I can go back and compare them, but they seem not succinct with each other. And maybe they are, but that would be, you know, it would be a shame to be doing all this work over here and
You're
then
right.
work over here and it not be combined. So
yeah, and I think maybe what you're getting at is one of the things, I think one of the previous slides, it talks about the CMS core competencies. So for DSPs specifically, as Abby said, DSPs will be DSPs because nationally that is a title that the developmental services world uses. So as we're building this, what will happen for an individual who takes the direct service worker training that we're building right now, that will get them in the door, right? So that will get them employed by a developmental services agency. Once that person is hired, and this might be where you're going with that, there will be a requirement for additional trainings that DSP must take in order to continue working with that service population because of the fact that there are different and additional skill sets and requirements that direct service worker must meet. So as an example, one of those could be rights and behavior regs training, right? So right now, a DSP has to have that training within a certain amount of time. We are not putting that in the direct service worker core training because that is really specific and unique to the adult developmental services population. So
will that live in Elsevier? Is that going to live in the College of Direct Support?
I don't know, actually. That would be something to ask, I think, as a committee member. That would be something to ask whoever's chairing that committee. They could give you that information. Unless you know, Abby, right now from your work that you've been doing with Miranda.
I'm not sure exactly where that will be hosted. The long-term goal for all of these trainings, all communication with everyone who works in this area, is the state's LMS system, which is currently in the process of being built. And we are at the beginning stages of building from the bottom up of just all of the communications and records and platforms for curriculum training. So I think eventually it will go there, but yes, in the short term, I don't know if it will go in Elsevier or not.
So I'm gonna.
Okay, sorry.
I'm going to call an audible timeout, Catherine, for a minute because I have a substantive question for you both, whoever wants to answer it, because I heard we heard from National, we heard from this, and I didn't hear. We did a lot of work with our stakeholders, and that they've been fully engaged in every component of designing this. And we shared this national information we got with them. They heard this too. We all heard this together and we're developing this model. I don't hear that. And so maybe I'm totally wrong. But how has How have providers been engaged at every step in working with you to hear what other models are? Because I've heard this Michigan model, right, includes everybody, behavioral health, kids services. They built it separately, so they didn't interfere with anything on the ground, that's got a lot of buy-in. And it's functional. And I'm like, okay, well, we've been now 2 years in this conversation and we're still just talking about two types, right, of providers. Not everybody, not quite yet there. So I just feel like, you know, my response is like, Catherine should already know all of this stuff, or somebody in the IDD world should know all of this that's happening and should have been a stakeholder, and there should be some way for Catherine to be participating on a regular basis in the conversation. So how does that happen?
Sure, Jess, I'll take that, Abby, and you can correct me. I at this point I can't recall the number of stakeholders we've met with, but to date, you are correct. We have not engaged direct developmental services and PSS provider agencies to date. We have talked to the trainers. We wanted to talk to the developmental services and the PSS trainers to have those conversations. We've had probably 3-ish or more conversations with them to talk about this. I do know that some of those, their providers came to the table as well, obviously, because a lot of them work for the provider agencies to provide input and about the process. So, and since then, we are in the process of creating the curriculum based on the CMS core competencies. And the goal is, once we have some of that curriculum completed, that we're going to then have those trainers go back in and go into a sandbox and really start looking at that. I will say, even prior to that, I know that our office director, Paul Saucier, had conversations with the DD community, as well as some of the folks from the aging services community. To be honest, I can't tell you who that was. I'm going to guess on the DD side, it was probably members from Maxby. And that was early on to review the concept that was brought to HHS, so that we did receive that sort of buy-in about this concept before we started engaging the trainers in taking those next steps. And Abby, please feel free to fill in any gaps that I may have missed.
No, I think that was a good summary of what we've done, taking back the things that people thought were really important. And yeah, no, nothing out there.
So we've heard, we just had a meeting not long ago with some members of a group, and heard specifically from Stephanie from Pathways. She actually said every week, so it's a behavioral health organization, every week she gets DSPs and PSSs in her door who want to start working as behavioral health professionals, who cannot, because there's no way to bridge quickly from their current credentialing to that credentialing. And so I just want to say we're missing a real opportunity to address an urgent need within the behavioral health workforce if we aren't bridging to them. And I guess I would just like to hear, you know, if we're not going to do that, if we're going to stick to a linear process of DSP and PSS, what are the bridge pathways to behavioral health? And by the way, nursing homes, CNAs, other entities. I mean, this seems pretty limited when we have a lot of people who want to move around quickly. And are there any conversations about bridges or other pathways to be created to make this easier for folks to move?
No, it's a good question, Jess. I guess I would just say, and go back to what Abby had talked about before. We did have behavioral health services come to the table with us along this path for a while. And unfortunately, they weren't able to join us. That being said, we're still providing them updates. And I'm hopeful that once we launch this project, which again, we're hoping to do in the spring of next year, that behavioral health services will be in a place where we can then look at, just like you said, what would the bridge step be? What would it take, given this core competencies that the Office of Behavioral Health Services for their MHRT programs can utilize to sort of join in this effort. And in terms of OCFS, I apologize, I don't have as much direct information about that. I think, Abby, you and others have been working with the Office of Child and Family Services for a little bit on trying to streamline maybe some of the developmental services curriculum for now. Is that correct? I apologize. I don't want to misspeak.
There are efforts underway to try and figure out what parts of developmental services curriculum between children and adults, as Catherine mentioned, can be done. So that works sort of well on its way. I would say that while OBH did not have the bandwidth when we started this project to join us, one of the ways that we have tried to make sure that they can join us at a future date is creating this course around the CMS core competencies. If we were to buy a bunch of curriculum from a provider like Elsevier or Elias, they have curriculum for mental health, for aging, for IDD, and they are all segmented by the CMS core competencies. They're just sort of different avenues, different flavors, different training modules, and they refuse to combine them. So by building the DSW course around the CMS core competencies, and we have a very large map going in the background to say, like, this is the lesson where they check off this objective and this, we're going to be able to hand this sort of roadmap to OBH and say, if you have the bandwidth to join us now, these are the ways that you could plug in. These are the mental health things that are missing from this curriculum, but here's how we could check off the things that we know that you need and that we know that you may need to build on. So we are building it in a way where hopefully we can plug right into that subject in the future. They just weren't able to join us at the start of this because they had a lot of competing other priorities for it.
Other questions for Abby or Karen on this topic?
Implore you to include provider agencies, not just the trainers, because this sounds like it's going to be a little more, it's going to be harder to get people credentialed and working, and that can't be that can't be a goal or a reality.
Oh, you are correct, Catherine. I absolutely agree with you. I think the plan here is we definitely will be getting providers involved. We still have some of those decisions to make, right? Because, we all know, for some of us who've been around for a long time and worked on curriculum in the past, especially in developmental services area, and changing that course, it's a lot of work. And our goal is to make this as easy and as streamlined as possible. So, of course, probably questions that you have already, Catherine, that probably others have is, well, what do the current credentials mean today moving into this, right? So we do not want we don't want folks to just say, we don't want to say, well, now you have to all take this training curriculum, right? So those are all questions that we have to, sort of make decisions on so that when we meet with providers, that we have all those answers, right? So we're anticipating those questions and trying to make sure that we make this not only streamlined for the future, but streamlined for a transition as this rolls out. Absolutely. And we will definitely be bringing providers into this. I mean, you guys are probably getting some of the first information fresh out of the box, if you will. But we will be engaging provider agencies for sure, and more than one, of course.
Yeah, I think it's a good collaboration point because I think there's positive energy on both sides for it. So, just from a departmental side and from a provider side, I think we are, I think from what I've been hearing from other sectors too. So
great, that's great to hear because we are very excited about this. With future plans as well, Jess.
Great. Good. All right. So I am looking at the time and am gonna ask a couple of questions here. Abby, are you able to stay for the entire time?
I apologize. I'm not able to stay for the
Okay.
entire time today.
Okay, so then I'm gonna make an executive decision and say, could you finish your presentation? Your updates, please.
Happy to do that. It's one more slide, so a fairly easy ask. There it is. All right, just have a marketing update for everyone on the call. The Caring for Me campaign directly and our contract with that particular vendor will be coming to a close at the end of December. However, we will be taking all of the resources that were created and keeping things going internally for the foreseeable future, strongly for the first year, but it'll just mean an end of ad buys. Jess, you have a couple of different seats in and around this. So previous advisory council members, things like that will be receiving their final report once they have that completed. We're really looking forward to lessons learned. What did you miss? What populations, what were the successes? What can we build on going forward? And then there is another marketing campaign, which will have, new graphics, new messaging, new research on how we can do things now that we're 2 years post when Caring for Me was started. And that'll be coming in hopefully early 2024. A vendor was selected and RFP'd, and we are working through that process right now to onboard them. They will also have an advisory group that they meet with. They're doing a little bit of background research right now, but we're working on that process, and I'll have an update for you hopefully at our next meeting.
Great. Thank you. Any additional questions for Abby based on that additional information? Any other members of the committee who have to jump off before the end of the meeting? Or can we move to the next part and then continue partner updates after the next presentation? All right, hearing none, then I'm going to say it is 1:58, and we've promised opportunities for participant comment. So if you are, oh, look at, we've got one already. If we've got anybody who's listening in, if you have comment, please raise your hand, and we will take you off mute and give you an opportunity to say what it is that you would like to say. And are you managing that, Angelina, or?
Yeah, I have taken our first public comment, Jenna Jones, off and promoted her, so she should be able to unmute and speak.
Okay.
And then I've got Jillian Jellicoeur on deck.
Perfect.
Hi, everyone. Thank you so much for the opportunity to speak today. My name is Jenna Jones. I am the Director of Policy and Advocacy at the Maine Council on Aging. The Maine Council on Aging is currently co-leading a grant to increase the number and kinds of people who are advocating on behalf of Maine's direct care workforce. This is Maine's Essential Care and Support Workforce Partnership, which we are leading with the Maine Center for Economic Policy and PHI. I wanted to let you all know about an upcoming webinar that we have scheduled for next week, December 12th. From 1:30 to 3 p.m. via Zoom, titled The 5 Pillars for, or Exploring the 5 Pillars of Job Care for Direct Care Workers. This is a webinar that is specifically designed to explore best practices for recruitment and retention efforts on behalf of providers. We encourage you to join. Angelina, I'm not sure if I can share anything in the chat, but if I send you the webinar invite, would you mind sharing it for me? Awesome. Thank you so much. Have a great day, everyone.
Jillian.
Good afternoon. So I showed up 20 minutes late, so I'm admitting that. So I missed a little bit of the first of the talk. But my comment is specific to what Jess said. Specifically during the pandemic, I'll kind of give you an overview. We're behavioral health, intellectual disability, and home care providers. So we provide all 3 direct roles. And pre-pandemic, we closed BHP services. And I also served on the commission, for where we're kind of going with this conversation. But I just want to mimic what Jess said, specific to entry-level roles, DSP, DLS, and PSS during the pandemic. If this rule had rolled out sooner, where we could have had people in different roles, it certainly critically would have helped serve underserved clients. We kept running into situations where we had a staff available, but because the staff was only a PSS, we could only put them in the PSS's house. And if we wanted to make them a DSP, they had to take CPR first. And then after CPR, they had to have their initial trainings. And had this already been set up pre-pandemic, I really believe it would have been a game changer. And it also would have set us up very fluently to kind of roll with these things. We do all three of the entry level services, and we are continuing to struggle with, we bring someone on and, you know, like, why aren't they full-time? Well, we can't guarantee full-time. They're only in this one role. That's not a guarantee. Well, we could fully benefit people that were dual or triple trained, you know, and if the Maine Care policy was a little more flexible so they could do those things, we could be giving people full-time work. We could be working people to the maximum hours that they apply for, but it's difficult because they're limited by policy restriction and certification requirements and different rules and different sections that don't necessarily, you know, the age, 17, is it 18? Is it CPR on hire? Is it not? The rules are not uniform. And I think we have to look at that uniformity. And I know our organization is very pro this, you know, type of direct care worker. And we're already taking steps actually to implement it without, you know, the funding and the rule changes. We're trying to figure out how we get ahead of this, because we can't offer full-time employment. We can't offer benefits because we can't guarantee them the work they need. Like if their one client goes in the hospital, I don't have the ability to put them with the, you know, like yesterday I got an applicant, say for Lisbon. Can't hire the person, but I might have an unstaffed case with a different discipline where I could have plugged them in, but because they require something different, I can't. So it's just that uniformity of rules certainly would have increased staffing and kept people better staffed. It honestly, as a provider of all three of these services, it's really difficult to sit back and watch that we haven't moved forward with any sort of training or anything. We're trying to pay them better. We're trying to guarantee benefit status. We're trying to give full time, but we actually had a representative or a senator drive by our sign and speak at one of these events. You know, Assistance Plus isn't offering full-time work. Well, these are part-time per diem jobs. We can't guarantee work without that dual role. So it just needs to have a lot of consideration, or these people are always going to be part-time. They're always not going to be benefited, and they're always going to be struggling financially and leaving organizations like ours because we can't even get them up to their requirements of hours that they applied for in a quick amount of time, because there's so many trainings and so many loopholes and so many policy rules, and Maine Care, dot your I and cross your T, and the three services really need to be blended. So it's a big task, but it's really long overdue.
Thanks, Jillian. Appreciate that.
And just to clarify, I'm also a train the trainer of the curriculums, and you know, I run the organization and I deliver the services, but we haven't been approached for any sort of collaborations or discussions.
Thanks, Jillian. Any other participants before we move back into our programming? Great. And Mary Jane Richards, I see you have joined us. Could you just introduce yourself as a member of the committee?
Yes. Hello, my name is Mary Jane Richards. I'm the Chief Executive Officer for North Country Associates. North Country owns and manages long-term care facilities, assisted living, and ICF, IID facilities throughout Maine, one in Massachusetts.
Thank you so much. Thanks for joining.
Welcome.
And Chris Hastad has also joined us as a guest. Would you like to introduce yourself, Chris?
Hi, everyone. My name is Chris Hasted. I work at Maine Legal Justice. And thank you for giving me the opportunity to listen to what you're all up to today.
Thank you so much for joining us. Great. So I think at this point, we're going to turn things over to Sarah Griffen, who is going to, for the first time since we've started meeting, start our conversation about the benefits cliff and finding ways to address that so that some of our workers can work more, which is really the goal. Sarah, please, thank you for joining us, and I'm going to turn things over to you.
Can you hear me?
Yes.
Oh, no, let's do it the other
That
way.
was too echoey. Let's see if. Now can you hear me?
Yes.
Clear. Okay. Hi. So as I said before, I'm Sarah Griffen. I do a lot of work around the country on two-generation work and do work in a number of states on benefit cliffs. And today you've asked me to come and talk about the benefit cliff suite of tools that Maine is currently deploying, and I'm helping to do that. So I thought what I would do is give a tiny bit of context and then kind of a brief history of where some of this came from. And then I can show you briefly a demonstration of the tools, as long as they behave and don't try to regenerate themselves. And then take any questions. Does that sound like a good agenda?
Sounds great. Thank you.
Okay. So, so some of the work that we are doing here in Maine around benefit cliffs actually started through at least a combination of things. I know MEGIP was doing some work on benefit cliffs, and we have had a regional effort called Whole Family Approach to Jobs, which is in collaboration with the Administration for Children and Families, Region 1 of HHS, working with the 6 states on a variety of two-generation whole family issues. And the Maine team identified benefit cliffs early on, in part through parent voice, as something that needed to be addressed for families to be able to move ahead. And so we commissioned a study on benefit cliffs that was done by Mike Levert, and took a look at what kind of was happening in Maine around benefit cliffs. And Maine has become really an early leader in the country in thinking about benefit cliff practice and policy. At the same time that we were doing that, and there was a kind of package, Chris, you're going to remember the name of it, together something that had some MEGIP policies, a bipartisan package, and some of the kind of some other pieces that we talk about in whole family that went through. In the meantime, the Atlanta Federal Reserve Bank was developing a suite of initially 1, and now there are 3 tools that can be used to support case managers, coaches, other kinds of folks working directly with families and participants to understand what happens with the cliffs. And I should stop and ask, everybody knows what the cliffs are, or should I be describing that as well, Jess?
I feel fair. Oh, Gloria is shaking her head no. So it sounds like if you could just do the briefest of primers, that would be really, really helpful. Thank you.
I can. Yes. So benefit cliffs happen when a person is receiving some combination of public benefits like food stamps, SNAP, like Maine Care, like TANF, and as they decide to either take a job or move, they've got a job and they begin to move up, they lose all or some of their benefits. And you will see in the kind of demonstrations I have here, that can have some unintended consequences of people having less resource than they thought they were going to have, and in some cases, less resource than they had before. And so part of the goal with the tools that I'm going to show you are helping families make, and I come from family, individuals as well, but make informed decisions. So sometimes we've seen in from research done both in Maine and in other states that people aren't sure what's going to happen to their benefits, and they are worried and nervous, and so they make decisions without knowing exactly what's going to happen that might mean that they don't enter the workforce in a way that they might otherwise. And in other cases, as you will also see, it means that somebody takes a job and they think they're going to have a little more overall assets and income than they end up having. And so this is really a way to help them plan for their current and their future state. The tools that we have here, I'll walk through them. We've been working to roll them out with, as I said, case managers and coaches, through some of the one-stops, through FedCap, through some of the community action programs, so that they can really begin to work with participants and help kind of lift up the veil of what's actually happening with benefits. Everything I'm going to show you today was developed for free by the Atlanta Federal Reserve Bank. They've done this for a number of states. Maine was one of the early adopters. And the other thing I would say about it is they are not exact to the penny calculations, but they're pretty close. The Fed has both watched Maine policy and makes adjustments to the tools as policy changes. And you will see the standard of living is the standard of living in Maine, and it's calibrated by town, since the north of the state and the south of the state, urban and rural, have different cost structures. And it's calibrated to the benefits here in Maine. So I am going to share screen. Any questions? Did that help with what the cliffs are? And good? Okay. Let me share screen. This one. Let me know when you can see my screen. There it goes. Okay. So this is the suite of tools that are available. And so this is here. I kind of want to show you the 3 different ones. And there's a whole online learning portal where the Fed has developed a whole set of online learnings. It's like 4 or 5 hours that people can take to learn both how to think about benefit cliffs generally, and then how to kind of use these tools so they can be well used across states. So there's 3 different ones. They actually started with this middle one, the dashboard, and then they've added in the snapshot and the planner. And they have different purposes. The snapshot is really, I am working at Burger King, I think somebody said, working at Burger King, and maybe I'm going to get a job in healthcare. And so I want to figure out, I'm getting a wage difference. What's going to happen to my benefits? What's going to happen to my overall package? It's a pretty quick tool. It takes, 5, maybe 10 minutes to walk through with a family. I'm going to show it to you. The dashboard allows you to look at your different career options, and it looks over time. So the snapshot's a moment in time. The dashboard allows you to look at different career choices and what happens over time to benefits, particularly as children age, because that does change benefit packages in addition to wage increases. And the planner, which I'm actually not going to show you today, is the most comprehensive and takes quite a while. It looks at both your detailed budget, exactly what your expenses are, and what your benefits are, and your income, and if you've got an educational loan or any other loans, what those look like, and creates a very detailed picture for a family. So as you can see here, snapshot is pretty quick, doesn't really have career focus, doesn't have a customized budget, only the planner does, but does look at the individual public assistance packages. So this is the portal that people come in through. And then I'm hoping, this is still up. Can you see my screen? And it now says Cliff Snapshot. Yep. Okay, I'm gonna hide something here from you so that we can just kind of walk through this. I'm hoping it will move over. Yeah, okay, so here's what I'd like to show you, and I'll show you the full complete in just a minute. So you can see state of residency is Maine. You can go by every city and town in Maine to see what the cost of living is, and it's calibrated through the United Way ALICE standards. For today, I've chosen 1 adult, 1 child. If you choose 2 children, it tells you the age of the children, or you can tell it. Does anyone have in the home have a disability? I'd like to come back to this because disability is complex. And there are some qualifiers that the Fed is about to put on the sites about disability. It's just the timing of disability that changes when you have income is a little squirrely. Age of first adult, I made 25. I decided the kid was 2. And with public assistance, you can choose a custom list. And here I chose SNAP, WIC, CCDF, Medicaid for adults, Medicaid CHIP. EITC, there are others that I did not choose. You can see them here: meals, TANF, early Head Start, pre-K, a Section 8 voucher, the marketplace subsidy, CTC, child independent care tax credit, SSI, and SSDI, but I just decided on these. And for right now, I'm using an estimate of housing costs. Now remember that, can you guys see this, by the way? Is it too small? I see people using their glasses. Can people see it?
It's fine.
Okay. You can put in your actual housing costs. The Fed recognizes that housing is one of the more challenging pieces. And so just a minute, it's hopefully going to come up for you. Yep. So here is what it shows. I've now put in an hourly wage of $15 an hour. You're about to have a minimum wage increase, so I'm a little bit above that. $17 would be your increase. You've got a 40-hour-a-week job. You might be getting a promotion. Maybe you took a training of the ones that we were just talking about. And then for right now, didn't do anything about money in checking or savings or sources of income, just for right now for ease, and said the employer does not provide health insurance in either case. And what it shows you is that the total family budget will increase by $93 a month. Now, what it does show, if you look at this first line, let me make it a tiny bit bigger. There we go. In the take-home pay, right, is that the family thinks they're going to make $263 a month more. But because they lose public assistance, that means that their net is actually more like $93 a month. Now that's better. It just helps a family to plan. This is actually what's going to happen with my budget. And then this next table shows what happens with public assistance and taxes, right? So they're going to lose some in childcare, they lose some in SNAP, and they actually lose some in EITC. They pay a little bit more in federal income and state income tax and FICA. And so that gives you kind of a breakout of what happens with the benefits. And then finally, it kind of shows your change in monthly out of pocket. So they're going to pay a little bit more every month for childcare, $35, and pay more because they've lost SNAP in food. So that's what the snapshot does. With your permission, I'd like to go into the other tool before it decides to reset itself. If I might do that, is that okay with folks? And then I can take questions. Just because
that's fine.
This tends to reset itself, so I'm just going to move this over and show you again similar. So again, just showing, this time I chose Booth Bay Harbor. I chose a 6-year-old instead. I chose, again, a set of benefits, won't go into them, SNAP, TANF, CCDF, Medicaid, CHIP, and EITC. And here, this is the tool that allows you to do career planning. So here I chose, you can go in and you'll see there's many occupations. I have to wait. Yeah, there we go. Many different, these are all from the Department of Labor. Many different occupations from which you can choose. So I chose psychiatric technicians. There's a bunch of different ones in here. And then you can choose to do one of two things. You can also put in the duration of an education or training program. This tends to be for longer ones because it means you'll probably be on benefits during the training program and then later have a change in your benefits. But you can put in a longer or shorter period. And with the occupation for comparison, for today, I've chosen near minimum wage job, but you can also choose another occupation to compare to. So you could choose 2 different occupations and work with a family to say, here are a couple of choices and what will happen with your earnings and what will happen with your benefits over time in these 2 choices. So it does help people in terms of thinking about their occupations. And so here is what comes up. Give it a second, there we are. All the way over. Let's see if it shows it. Okay. So that gold line is the near minimum wage job, and the brown line is psychiatric technicians. And you can see here, this is the training year, right? And then it kind of goes up over time. And this is important longitudinally because that 6-year-old is going to get older and the benefits change based on that, in addition to the income. And obviously, if policy changes, these graphs will change because the Fed has a whole database, Fed Reserve, that it updates regularly. So that's kind of a picture just of straight income before taxes. And this one now shows your same thing, take home pay. And it also shows the minimum household budget, which is this gray line. And this is without any benefits at all. And so this shows you, again, built on a self-sufficiency of around 40,000 for a family of 2. And you could say that might not be enough, but that's what the self-sufficiency standard from United Way looks like. Pretty sure it's United Way, not MIT now. And then you can kind of see that they're break even. First, it would happen for the psychiatric technician after like 5 years. And it really takes a very long time for that to happen for the minimum wage job. And in fact, this is probably when the 6-year-old goes out of the home. Is why it changes, right? So that's the next thing. And you can look, I'm not going to click on it now because it'll go a little weird, but you can look at what's in the minimum household budget to see how it's constructed and where it comes from. And this is one place where, you know, families may say, well, that's not really my income. And so you can work with them and say, well, what are your expenses, to kind of figure that out and whether they calibrate to what this chart shows. This chart now shows you what happens with public assistance for the 2 occupations. So on the left is the near minimum wage job, and on the right is psychiatric technicians. So at the beginning, the near minimum wage job, you actually are not getting any Medicaid for adults. You just have that. This is CHIP, this yellow. This small one is CCDF, right? And that's probably when the kid goes to, that's age 6 to 12. That's right as the kid ages. SNAP goes, and then you can kind of see what EITC does. And then over here, technicians don't actually stay on benefits for as long because of the wages. They get them for a couple of years and then they drop off. And then finally, you can see what happens with net financial resources. So you can see a couple things here. One, in that near minimum wage job, this is a break-even line, the black dotted line. In that near minimum wage job, it is hard to break even, period, right? This is, again, probably when the child goes to college, if I do, yep. It's about when the child goes to college or out of the house, college, technical school, whatever. This is what happens for the psychiatric technicians. So the first thing you can see is there is a little cliff here in this first year where, they're doing better, but they lose some benefits. We can go in and look at what they are before they then start climbing up. But they also climb above break even within 4 years or so. And so then they do much better as they go along. So this, again, is a way to be able to talk with people and say, okay, look, you're going to have a dip for a year from what you had before. How do we help mitigate that? Because after that, you're on an upward trajectory. It could be, how do we recalibrate? How do we get you to break even? Where are the other resources we find for you, etc. Or maybe it's, and I don't know if that is possible for psychiatric technicians, maybe you need to pull a couple overtime shifts each month to make up that difference. But it helps people plan for their families to make sure that there is stability for families while people are trying to move into careers that they want to be in, and then, kind of stay in those careers. So that's kind of that piece. And then finally, and I will click on this, compared to the minimum wage job over a lifetime, a psych tech will earn, looks like, about $550,000 more. And this is very often a compelling graph for folks because it helps them realize that over a lifetime, my choice to become a psych tech gives me so much more in terms of resource than if I stay in a minimum wage job. So that is essentially the set of tools. And I'm going to stop and see if you have any questions. or comments or thoughts? I can't see raised hands. I'm fine with people shouting out.
Betsy.
Yes.
Thank you. I'm just curious, how do you get people beyond that immediate, wanting to see that short-term gain and not, I mean, are there incentives that have been worked through? Are there ways in which states have mitigated that in some fashion so that folks can, I mean, you look at it on the long run, it looks amazing and you can see the trajectory and you can see how much more income stability they're going to have. But how do you get folks past that sort of immediacy of feeling a sense of loss or discomfort or anxiety or risk?
So excellent question. And so 2 notes. One is, I was actually talking to the Fed Reserve this morning, and they are planning to put kind of a piece of a coaching manual together because this is one of the critical questions. And 2, I think here in Maine, so we both are rolling these out, and then we have some regular office hours if people want to come in and talk. It's kind of learning from each other how to do that. Because I think there's both the coaching side of it, which is important, right? And then there's the kind of what's possible in policy. And there's not, I would not say I've seen a ton in policy. There have been there are 3 benefit cliff pilots operating in the country right now to try and kind of look at what's happening in benefit cliffs, one in Florida, one in Tennessee, and one in Washington, D.C. And very interestingly, they've had a hard time recruiting folks, even I think with some modest incentive. I think the thing that we are hoping to look at is, so let me also say another thing about benefit cliffs. Some of these benefits are controlled, as everybody here knows, I think, at the state level, and some are mandated by statute within Congress, right? So there's kind of statute federal, which is hard to change, especially right now, Congress doesn't seem to be doing well in getting things through. But so it's hard to change there. There's regulatory, which is, right, federal agencies interpreting federal statute. There's a little more latitude there. And then there's kind of where states have control. So as an example, SNAP, there's very little control at the state level over policy to create the kind of incentive you're talking about. That's just much harder. Same with Section 8 vouchers, the kind of policy is there. TANF has more flexibility, but doesn't always have unlimited funding. One thing I do want to point out, which I hope folks will find positive, is in just about a month, there's a number of states, including Maine, that are convening in Washington with the Administration for Children and Families, the Department of Labor, who's coming, Medicaid's coming, I think child care is coming, TANF's coming. So we're going to have 12 states kind of looking at all the different ways that, to your question, Betsy, state policy can shift and be utilized to kind of help mitigate the cliffs. And then it's also going to be a time to talk to the federal government and say, there are things that we can't do, and we need your leadership and help so that we can then do some work to really support families towards their economic goals. So it's not a perfect answer, but there's both kind of a practical, we're figuring out how to do that coaching, and then there's a kind of some of the question around policy. And I'm hopeful that, I'm not saying change happens so quickly in Washington, but at least we're beginning a dialogue about the interplay between state and federal policy that makes it hard for families to move ahead.
Chris Hested.
Hey, Chris.
Hi, I was just going to follow up a little bit on Betsy's good question. And thanks, Sarah, for the presentation. I mean, this tool is a valuable tool. It in a couple of ways in our view, it really helps to initially deal with the perception that we see among so many people that I'm going to lose everything the minute I go to work. And that's just sort of a big help in and of itself. It is also, though, and it gives a great gross picture, and it's particularly useful when you start looking in the out years at the different career paths. What this is not designed to do, and I think what Sarah's alluding to, the need for more conversation and the hope for more conversation about, is how to do two things. One is to work with individuals in a very direct way to sort of help them. This is not an individualized tool, to help them really understand what might be available to them. So for example, you go to work and you may lose some SNAP, but wait a minute, there's a provision in SNAP that provides for you to get your old SNAP benefit for a period of time when you go to work. We've just redesigned TANF to provide, in Maine, to provide some pretty extensive support for people that are just leaving TANF and going to work. And Representative Craven will remember that her committee was part of that work. And then there's a couple of things that and then there's the whole sort of question about what more can we do on the policy side. And Sarah's right that it's hard to work with a lot of the federal law that doesn't provide for state options, but there are some state options and there are some opportunities, and collectively we've been able to take advantage of some of them, but there hasn't been a really distinct focus on, okay, here's this problem with direct care workers and the financial problems they face. What policy changes could we make in these programs that might advance opportunity for them to not lose so much income? And so I don't know what the scope of this committee is, and I'm delighted to see you here, and I know you're all good people and you're going to do good things. But I also think there could be an opportunity to sort of have some direct conversation about what opportunities do exist. And it's not just in DHHS programs. On the labor, unemployment insurance provides partial benefits that, are a huge of huge value to people whose jobs, the workers whose patient may go into a hospital for a period of time and experience a decline in income. So there's just a lot of pieces that we could work together with, and we could do that on a policy basis, and we could do it on an individualized coaching basis. There's a new program that was created a couple of years ago that provides transportation assistance to families with kids under 200% of the poverty level. And that just basically gives them a mileage check every month for the distances they traveled. And that, that isn't going to be found on this tool, but in an individualized coaching situation, then you would be able to sort of help workers dig more into how can I, with the programs that exist right now, maximize my income. I remember years ago, there used to be a shoe shop in Norridgewock, and they had a person there whose job was to help workers at that manufacturing plant maximize their income through applying for SNAP or food stamps in those days, applying for TANF, basically getting. And so those kinds of individualized coaching opportunities and a more deliberate look at policy in this area feel like two important things that we could be doing right now.
Yeah, and Chris, I would maybe moderate a little bit of what you're saying about the individualized. This does individualize it. I need to check with the Fed. They may have included, but not on a monthly, more of an aggregate inside of annual, the new changes around TANF transitional benefit, for example, and the food supplement benefit. I need to double check if they've done that, but you are right, it doesn't include transportation. It has some level of individualization in that it's for Maine, and if I am getting TANF and SNAP and I have this kind of a household size, it shows me roughly, not exactly, but roughly what might happen. So I think that's true. The other thing, yeah.
What I think Chris is saying, and correct me if I'm wrong, what it doesn't do is, so it tells you what the trajectory is, particularly like I look at the slide and what I want to, I made my own slide. I took a screen print of this and already made my own slide. I want to see like a line from that point all the way to where it starts going up. I want to see that be flatlined, so, you might not be gaining, but you're not losing, so that you're willing. And what do we need? What already exists? So this tool isn't going to tell me what already exists to help me with the safety net, because I'll tell you, a lot of people aren't going to make it on that dip, and we know that.
Yeah.
You know,
Agreed.
so that's where we don't have, this tool does not help with individual navigation in that way. Like, how in my personal situation am I gonna make it work when I lose my childcare subsidy?
Yeah, I guess what I would say is this is a starting place, and then you layer on much of what you're talking about, and then I think you get to the equation. And, you know, as I said, this is a rough, right? My housing may or may not be what they have approximated for housing in particular, right? But I do think it helps, Chris, something you said, right? People are scared, and understandably, the two benefits that people are most afraid of losing are Maine care and childcare. And Maine care in particular. If you have a child who has asthma, you are making calculated decisions about whether to try to move ahead or whether you need to be careful and take care of your kiddo, right? And so I think that's one thing that it does really help do, which is, okay, let me understand more about, and you need a coach to do that, to your point, Jess, to your point, Chris, let me understand more about what my option is here. The hope is that this is going to help people then think about, okay, this is the package of things that this is showing me that, you know, Chris, you just pointed at transportation or at a transitional benefit. This is what I can do to make it work. There's also times when people have to go, you know what, I need to wait 2 more years for my kiddo to get to a place of whatever before I can take the step I want to. This is about, at least in my book, families being able to make wise decisions for themselves, that they know themselves best, what needs to happen, and then to be able to then have access to every opportunity that they hope to have in a way that takes care of themselves and their families. And it's not, nothing in this world is perfect. I do think, you know, Chris, to your point, and just to your point, I think, you know, there are some policy pieces to look at. I think it's the untangling of the federal to state is a thing. It kind of what's federal, what's state, what's regulation, what's statute. I find that has been a fascinating journey, but it just popped out.
Yeah, I just actually stopped sharing just so that we could see people's with raised hands and things like that.
Sorry, Jess. Okay. Betsy.
So this, as Chris, you and Sarah were talking, I was thinking, I haven't been in the community action world for 15 years, so I've kind of lost my knowledge about a lot of those programs that you were alluding to. And, you know, I guess I'm sitting here wondering, do we have navigators to help people figure out those, I don't want to say loopholes, but those parts of the programs that have some flexibility or have some built-in safeguards? Because all of those things that you mentioned, I have no knowledge about, and I'm in the aging world now, so you know, it may not be as applicable to us, but is there a system of navigation in our state?
And I'm gonna put one more reason why Betsy's asking. And Michael, I don't want to put you on the spot, but I've heard you say over and over again, and I've heard other providers say, if I could just get a worker to work 10 more hours, it would make a significant difference on the number of people we're able to serve. And that's what we're really looking at. Okay, I just want to ground us in why we're looking at this, is that we have thousands of people who are not getting care, and I'll use that word very specifically, care, who are supposed to be getting care in this state, who are very vulnerable. And we have people who are not working but could work, but are not because of this problem. So I just want to be very clear that there's a really important reason to understand what's available and what we can enhance to get there.
And let me just say before, Kim, I don't know if you're responding or asking a question, but let me just say this started actually in one of our, at least from the piece that I was involved in Hope Family Approach to Jobs meeting, where a parent said, she was doing social work or human service work. I've been asked to work 5 hours a week more, and I have said no, because I need my health care. She also was the one who was the same parent, who said that, remember a while ago, SNAP had like a $5 a month benefit for working families and it got boosted to 50. She said, you know, that $5 a month means a huge amount to me. And that was part of, I think people were listening, and that was part of thinking that about we need more food supplement for working families. Kim, are you asking a question or responding to the matter?
I'm responding. Can everybody hear me okay? Okay, thank you. Are there navigators out there? Yes, but I'm going to have a caveat there. Yes, Sarah has been really intensively working on training. Certainly all of the participants in the Whole Family's Approach to Jobs Network, they're constantly approached. They're obviously we're some of the leaders in this work. My staff, Career Center consultants, Competitive Skills Scholarship Program, the Title I-B program providers, so some of the employment and training folks, our peer workforce navigators in partnership with Maine Equal Justice, SNAP ENT, FedCap. So all of the folks who are already in these individuals' lives, who are probably likely, they're having these conversations with them anyway. We are working on making sure that, number one, they know how to use the tool, and then they know how to coach someone with it. That said, here's my caveat. If, Chris, all of the awesome brand new legislation that might be able to extend benefits, if those are not integrated into the tool, and I know Sarah's looking into that, then absolutely we need to have at least an annual update of every single one of these coaches, maybe a resource guide, where we can work probably with Maine Equal Justice to make sure that this coaching network has the most up-to-date information about those really interesting programs and services. So it's a yes, but are they perfect? Not yet, but Sarah's been an awesome coach for them as well. And they have had these each month they have office hours to be able to share challenging situations, how I coached a family through this type of situation, and they kind of bounce ideas off of each other. Chris, did you have? Go ahead.
Kim, whoops. Can I ask a question about that? For folks in the industry here, is there a direct connection so that if someone if Betsy had a worker who was struggling with this issue, she would know to connect that worker to someone at the Career Center who really understood and could, help that worker navigate that stuff, or at a CAP agency, or in other words, is that system well established so that when you have a person on the ground saying to their supervisor, I'm having a lot of trouble, there can be an immediate referral to that, and we can count on that person at the other end of the line to really be knowledgeable enough to walk that person through it. So that's my question.
That is an excellent question, and that is exactly what we're working toward, Chris. We sometimes things work a little slow in government. I said that out loud. HHS has wonderfully agreed to host a website for us. Then we're having a meeting, Sarah, here in the next week or two. My push is that there should be a public-facing page that allows individuals to connect to their preferred coach near them. And of course, they can provide services virtually or in person. But yes, are we going to provide a direct link to the tool? At this time, probably not, because you saw how complicated it is. Not complicated, wonderfully complicated it is. It needs to be.
Well, and the Federal Reserve Bank actually recently said they would prefer it not to go public for some of the reasons that we're talking about. So I would just say that out loud. And Chris, I would say, yes, we're working toward it. People have been trained. They've had an orientation, they've taken the training. Do I think they're facile with it? Like, it's like boom, boom, boom. They're actually a little nervous about it, right? Because if you worked on the tool yourself and you hit calculate results, all of a sudden you have to interpret what's there. And at the same time, you're trying to coach somebody in thinking about their career goals. So what coaches have said to me is that what they're doing is actually getting the information and doing it, and then bringing it forward after they've had a moment to absorb the results. Because it is complicated, and you're trying to figure out how to support a family in making a good decision, right? Without kind of looking and going, oh no, right? I mean, you don't really want that. You want to be able to have a good response. So are we totally there in terms of having, you know, everybody in the state expert? I would say no. Have we exposed probably, I don't know, I want to say 150 people throughout the state. We've done it for Spark as well, some of the Spark navigators. We're doing our best to blanket the state so that, to your point, Betsy, your folks can walk into a CAP, they could walk into a career center, they, you know, any number of venues there in community college, they could go talk to one of the Spark navigators, and they would go, yep, we know that tool, and be able to work with them. I just wouldn't say that everybody's an expert yet, but we have done our best to saturate the state in the way that Kim was saying.
That's great. Can I make one little pitch, and then I promise I'll stop talking so much? Unemployment insurance is such an incredibly valuable program, and the so-called recipiency rate in that program is very low, because a lot of people think just screen themselves out of eligibility. They think, hey, that's a program that's been around since the 1930s and it's for old manufacturing workers, and I'm not that. But really, they may be eligible, and it's a lot more money than TANF, and it's available to partially unemployed people. And so I'm listening to the conversation earlier about people whose hours change so much. I would just, even though it's a different department, we love both departments. They have both got valuable programs. I would just urge you to incorporate that into the training if it's not there already, and it may be.
Yeah, and so we can bring it up as a thing. I have to talk to the Atlanta Fed about whether it can be incorporated in the tool, which is a different question from incorporating it in people understanding the package, whether it's transportation or UI. The Fed has some massive database in the back that cuts across all 50 states. So it has to be something they feel like they can do across. I just don't know. I'll ask them. I asked them this morning, actually, for the snapshot, about whether or not they could put in, if your employer does provide health insurance, can you put in an amount that your monthly copay is going to be? Because that would help with calculation. She's going to look into it. The Fed folks are very receptive to, they've been updating it constantly. They've been really great. So that's the kind of thing, Chris, that I'm happy to bring back to the Fed Reserve and say, what about UI?
Yeah, and what about LIHEAP and LIAP? You know, I mean, the problem, there's a million problems with the public benefits system in this country. One of them is it's so truncated between different departments and organizations. And so, you know, DHHS doesn't administer LIHEAP or LIAP, Department of Labor does this other program. I understand what you're saying, Sarah, and I can imagine the difficulty in doing that. But those pieces really help a family put it all together.
Yeah, we asked them to do, it's curious, I need to double check with them. We asked them to put LIHEAP in there, and I'm not sure why they didn't. So I will ask why. Good question.
So, you know, I'm very aware that just a lot, that this is a lot to ask for people, right? I mean, I agree the tool is a very useful tool for navigators, but that's a big jump for people, and without a lot of who may not have skills or the ability, and we're not talking about cars breaking down, right? We're not talking about unexpected expenditures that are unavoidable, that people don't have any, they have nothing, right? I mean, there's nothing between them and homelessness in some instances, so and working 10 hours more would really help them. I mean, that's where, you know, I come to this to say, you know, what is the solution of creating some sort of a hill instead of a cliff? And great tool, but clearly doesn't solve for that problem. That people, a lot of people just can't do it. And I heard you say, Sarah, very clearly, this tool does help somebody see this isn't the time for you to make that, because you got to take care of your family. I heard that loud and clear, but it's still coming from, this all feels like it comes from a place of privilege because we aren't there. We're not the ones here having this conversation, trying to say to somebody, yeah, sure, you can do this. It'll only hurt for a little while, only hurt for 4 years. That's a long time to hurt.
Sure.
That's a lot of pain. And anyway, no, I'm actually, Sarah, hang on for a second, because I'm actually directing my question to Chris. So I would love to know if you, because we've talked about this a lot, Chris, if you have any new or renewed thoughts about things we can do, within existing situation, how the state, and I mean legislation, I mean spending money, I mean, all of those things. Are there some things we could do to help cushion that kind of a blow? Right? You're going to come off your benefits, and it's going to be a 4-year trek before you get back to where you were. What are the kinds of things we could be doing, if anything?
Yeah, I mean, we've made long lists of these things before, Jess. That's the kind of suggestion I was making earlier when I was saying this tool is good for what it is, but it doesn't change the policy. It wasn't intended to change the policy, but it sounds like Sarah's thinking, I'm sure Sarah's thinking about the need to change policy. I think it takes, a little subgroup of people sitting together and thinking through all the different programs and all the different options that might exist to do that. Could I give you a list off the top of my head? Sure. But, Sarah might say they're crazy. And so it would be really useful to sit with some people from the department, some people who are advocates, some people, who are seeing the pain that people are enduring, or are enduring themselves, and figure out what can we do here? What are the options under these massive federal laws that aren't insurmountable? I mean, we sure, there are laws and rules, they're federal, they're big, but there's opportunity there. Yeah, but it takes, I think, a partnership to put it together.
Sure. Well, and that's why, that's why we invited you here, and what this committee exists to do. We actually have been charged with examining the benefit cliff effect on essential support workers, and recommend and develop a pilot project to mitigate benefit cliff effects on essential support workers. So that's why we're here, and we're all together. It's one of the key purposes of this. So this is really the start of that conversation. And so that would be kind of your recommendation moving forward. Maybe develop a subgroup of this committee to go away and work with you and Sarah and others and experts to sort of say what's possible, and then maybe come back after a bit to make some recommendations. Does that make some sense, committee-wide or as a process?
I think that would be a useful thing to do. How much time I can put into it, I can't promise you right now, but I'd be definitely willing to think about it, at least initially think about it. I think it takes, people in the 3 departments. We just did this work with the LIHEAP folks a couple of years ago, where we established categorical eligibility. So if you're eligible for SNAP, you're financially eligible for LIHEAP now. That's a big deal. Betsy will remember that from her old days at Prop. It simplifies the application process, and makes the program more accessible to people. Anyhow, there's a lot of things like that, but it really takes all the departments' engagements to help us know whether they're going to feel like they can do that, what they need for technology to do that, what's the cost of that, do you agree we can do that? But I think that's right.
Thank you.
As usual.
Now for a couple
Sarah.
comments, Jess. Yeah,
Sarah.
so the great smoother, the great policy change is state EITC. Because what happens, I don't know how to take my hand down. I'm really bad at technology. what happens with benefits, right? And Chris, yes, we can look at them all, is you do one and it affects the other one inadvertently. So in Florida, they tried to solve for the housing, I can't remember which one, the housing or the childcare cliff, no, the childcare cliff, and they inadvertently put it smack up against the housing cliff. And people were like earning $1 more an hour and falling like thousands of dollars behind. So the state EITC, because it doesn't count against any of the benefits, is actually the policy that helps the most. And you did increase your state EITC. I'd say you have to catch up to Connecticut, which is at 40%, but which is not quite as high as Maine right now. But that is, when Jess, you're asking for solutions, that is kind of the great smoother that enables folks to keep their benefits and still get the benefit of working. There's some, squirrely aspects around it comes once a year, and it would be helpful if it was every 12 months. We could talk about that, but I would note that just because the challenge, even in figuring out what, making a lever work here or a lever work here, is it inadvertently upsets other things. The other thing I would just notice, Maine has done some good work in policy. Just about anything that happens is going to cost significant funds. It's part of why we wanted to go to Washington and say, come on, right? This is a national benefit cliff, is not, and it's across the country. It's not just in Maine. And the federal government having some responsibility for supporting people to be able to go to work. To your point, Jess, 10 more hours, right? That there should be some kind of piece there. So that is part of why we're having this meeting in DC, is to begin to say, yep, states have been doing a lot. States are trying to do this work, and we need some movement at the national and federal level as well. But I would just point out state EITC as the thing that is really the easiest mechanism for mitigating the cliffs.
It is, and there's also starting to be a more serious discussion than in the past about guaranteed incomes and ways in which those, and there's a lot of pilots going on around the country there. That has at this moment the problem that Sarah points out, accountability against the other programs, but there's a recognition that needs to change and have the same provision as the EITC so that it's not countable. We can make some stuff not countable that we haven't too. So, again, I don't want to say there's endless opportunity out there. We do need some fundamental federal change to make these good things happen, but both avenues we need to sort of follow down.
Great. Catherine. No. She's over that.
I'm all set.
Okay, great.
Yeah.
Any other questions? This has been a terrific conversation. Sarah, Chris, thank you both for being here. Other questions for Sarah or Chris before we move on?
Thank you for your interest.
Oh, well, yes, absolutely.
Important and critical. Yeah.
Absolutely. Is there public comment? If folks have any comments they would like to offer at this time, please raise your hand and Angelina will promote you into the meeting. Anything, Angelina?
I've got nothing. No hands are raised.
All right. Well, you've apparently done a great job. And we will see if we have some folks who are interested in spending some time. And Chris, I didn't mean necessarily you, but you are definitely the person with the who's been thinking about this for an awfully long time. But we'll see. We will loop back with some folks who are interested in working on this issue.
Yeah.
Thank you. So shall we go back to partner? Well, actually, no, we've got Karen Lee Harrington here. Let's do that, and then we can wrap up with partner updates at the end. Are you okay with that, everybody? Just so we use other folks' time appropriately. So, and folks are please welcome to stay throughout our conversation. So the last piece is that we invited the Maine Health Data Organization and Karen Lee Harrington to join us at our last meeting to learn more about what they do and how they do it, and agreed that some of us would have some conversations with her in the intervening months and come back to chat a little bit more about what we have learned and what we have landed on in terms of sort of a conversation with her and what is possible. Lots of things are possible because it's a pretty darn cool organization. Is thinking about could we create some sort of a using the Maine Health Data Organization, create a reliable way to collect data and bring disparate data together in one place about the care gap specifically. In other words, the people in Maine who are entitled to receive care, whether those are folks with intellectual disabilities or behavioral health challenges or older people across the full continuum of care, who is not getting care and how much care are they not getting, and begin to measure the care gap. And so what we've been talking with her about is potentially having this committee consider and then recommend it would have to come through the legislature because there would need to be a little bit of funding with it, but essentially to create a model that would say, here is where all of this data is. And some of that data is with the Department of Health and Human Services, and some is with Bureau of Health, and some is with providers themselves. And so they're sort of all over the place. So not new data, but let's not talk about collecting any new data. We do want to know where there are data gaps, right? Where we don't know what we don't know. And how can we think about that? In other words, one of the things we've been talking about with nursing homes is, how do we measure beds that are offline due to the staffing shortages, right? So how does that come into play if you're talking about a care gap? With the idea being that until we fully understand how much care is currently in Maine authorized but not delivered, we aren't going to understand how many workers we need to recruit into this workforce to solve for that shortage. In other words, we can ask every employer in Maine, right? How many vacancies do you have? Right? That's one way of getting at, right? But that just tells us how many providers those individual agencies could hire based on their funding sources, and it doesn't tell us whether that number would meet the care gap, right? Those two things don't equate in any way, shape, or form. And because the data exists within different state agencies, and they really are within several different state agencies, and outside of state agencies, in other words, with some providers, we think it makes the most sense to have the Maine Health Data Organization be that collecting agency, and think, instead of going right there, right? Okay, go ahead, let's start collecting. We think maybe it makes a lot of sense to ask Maine Health Data Organization to explore what it would take. So what data exists currently, from what data sources, how could you build that model? What would it take, right? What would it cost to be able to make meaningful sense of that? We don't even have one thing does not necessarily equate to another. So for instance, what I was just saying, an empty bed doesn't equal 10 hours of care that goes undelivered a week to somebody with intellectual disabilities or in home care. Sorry, I'm tired. And so thinking about like how does that translate, right? So how many workers, or what is how do you define a care gap from an empty bed to a number of hours that go every week unstaffed, and how do you create a model that looks at well, some people are partially staffed and sometimes they're not staffed, and how do you look at that person over a year, right, to see how many hours over that year did they not get? Are they mostly staffed or are they mostly unstaffed? Those are things that we can't really get at right now in understanding what our current care gap is, and then ultimately what our workforce needs to look like to be able to meet that care gap. So that's a very top level way of saying we think that this is a credible organization and a potentially great pathway forward to solving some of this initial question about how many workers do we need, and starting to create a baseline to measure over time, is that care gap shrinking? Right? Are more people who need behavioral health care getting behavioral health care, right? Are more people who are entitled to home care getting home care? So I'm gonna stop there, and Karen Lee graciously agreed to join us, particularly for those of you who maybe weren't able to join us in the last meeting or listen to the recording, and just want to stop there and say, what questions do you have? What do you think, what questions do you have of Karen Lee about MHDO generally, or about the proposal? And hi, Karen. Thanks for doing it. Betsy.
Well, I think it's a great idea to have a third party really compile this data from the places that it exists. I do think that having the data on what the authorized hours of care versus the hours that are paid for would tell us a lot more than just what the unstaffed hours are that we carry inside our own agencies. I don't know how we get to, though, the people that are waiting for services that, for example, Section 96, we haven't taken a Section 96 referral in months because there's an issue with the payment methodology and the rounding rule that Maine Care put in effect. It's got me into a $200,000 deficit after 4 months of programming. That's just my agency. So I there's a lot of, I don't know what's happening to those people. I'd like to know, are there programs that it may not be evident that there are people not being served, but what do those look like too? I don't know whether they call them wait lists or what. There's data gaps that I think could help us plan better for this workforce, from everything from the people in the home all the way up through the people that need to do mental health work, or they need to be care coordinators, or they need to be doing any kind of work that has to do with the care community. I would hope that we could figure out some ways in which we could capture data across jobs, not just the folks that are actually doing the in-home care or in facility care or in group home care, or whatever the type of setting it is, or the homemaker. So that really it's layers of care workers. Not a question, I guess it's a comment.
I think it just speaks to, Betsy, it just speaks to the complexities and our inability to access or obtain a data set that really is able to, guide us. So, to me, it just adds rationale to try to have, MHDO, I was going to try to do the acronym right, but MHDO do, an inventory and just sort of some level setting and, like I said, like if we came out of this committee with a way, and I know we have bigger aspirations than this, but like if we came out of all this with a way to monitor, measure, react to the workforce, I feel like we would have accomplished a lot, and it's too bad that we don't have that ability to pull data and have that be meaningful. But I think there really is some opportunity there for us to be able to do that.
Representative Craven, sorry.
Oh, thank you. Well, I had a bill last year, last session, actually, that would require the department to do just that. And it got convoluted into something that doesn't seem very useful. Maybe Betsy remembers the argument that there was a lot of conversation in the committee about it. And so I maybe candidly could talk about what the barriers are to actually just compiling something like that. And I can look for my paperwork to see what the opposition from the department was, but it didn't go very well. It got passed, but not in that form at all.
So
What was the LD number?
Yeah, I was going to ask the same question.
I'm going to have to look. I'll
That's
get
all right.
back. Yes.
While we're talking, while Karen Lee is telling us, I'll check it out online and look you up by name, Margaret.
I was just going to ask Representative Craven that if she had the LD number, because I'm not familiar with, the bill or the debate or what happened. I certainly, will talk with the department. I mean, we've been asked if this is something that is within our wheelhouse. And when I look at what the legislative, mandate for the organization, for the Maine Health Data Organization is, I mean, we are creating uniform data structures and systems, a comprehensive database to help improve the health and healthcare costs and quality of Mainers. I mean, that is essentially at a high level what our statute mandates us to do, and we're to promote the transparency of healthcare quality and cost data. So when I was asked about this, I feel like it is not something that is outside of what we would, right? But as I've shared with Jess and others, data collection is difficult, right? You need standards that define certain data elements. You need the infrastructure to take the data in. You need to be able to not just take it in, but put it in a structure that then it can be released so that others can use it to answer questions, or we can use it to answer questions that people have if people don't have the capacity to take this data in and analyze it. So that's all stuff that MHDO does. And I think over the years, we have developed the infrastructure and the tools and the competencies to do that work. This is a little bit outside of what we already do now, but we have some examples where many years ago, MHDO collected data on nurse staffing ratios for the state when it was looking at that policy around staffing ratios. So, we've done this type of, sort of similar, trying to understand when there's a problem, how do you build a data set to try and answer? I think the first part of this, doing that inventory, certainly would want to talk to the department about that. I mean, again, we've done environmental scans within the state and within, external to the state in terms of data that is available. So again, we have some experience with that. I'm not sure what, and I'm just talking high level, not specific to this in the department. Clearly, Maine Care is our sister agency, and we want to be working collaboratively. So, I guess I don't have much more to say than that, other than that. If I can get the LD number, I'm happy to, have some internal conversations about that. But, my sort of response to this point has just been responding to questions about what we do, and is this idea of MHDO doing this inventory and potentially, making a report on what it would take to create such an infrastructure, is that a possibility? And I think the answer to that is yes. But that doesn't mean it doesn't come with a whole bunch of, I'm sure, real challenges. But I like to think that the challenges are opportunities to try and figure this out. So I don't know, Representative Craven, that's probably so long-winded, and I've had probably too much coffee today, so I apologize for that. But that's kind of what I've been thinking about as I've been having these conversations with this group and with Jess offline.
Well, thank you.
And you have a lot of bills, Representative Craven. It's not readily apparent which one it is. But hey, if there's one, that's a potential vehicle too. But
My
pardon me?
My aide to look it up for me. I'll get my aide to.
Okay, great. That would be great. And other thoughts, Michael, Don, don't know if you've got ideas on whether this would be helpful or not.
No, absolutely. As I shared before, I think this is critical. Yeah. So, and again, I'm sort of in the bucket we've already got and are capturing, and so we're starkly aware, at least within our little world, of what that need looks like. And I think then can add the value too if others had the capacity way to sort of capitulate that together. I think would just speak volumes, certainly in that respect. So I'm absolutely on board.
Don?
Yeah, I too would support that. I think there was something similar set up, at least on the mental health side of things, where our organizations are listing beds that are available. So we would have a sense of capacity. I did want to say, though, even when we were talking about the outpatient programs for mental health, some of these things are still driven by the reimbursement rates that are insufficient to support these services. So as we talk about a wait list for outpatient services, particularly in light of what happened in Lewiston recently, organizations know that a traditional outpatient model, if it isn't an affiliate model, if it's employment by an outpatient clinician who you're hiring full time, those models really are not sustainable. So we, like others, intentionally keep those programs small because they will tank every other program. And I think it kind of keeps circling back to that same thing with some of these insufficient reimbursement rates. In light of the Lewiston tragedy, we took on, right now, I believe the last count, we have 40 clients that were either directly or indirectly. And honestly, that's to our own detriment that we took on clients, because it's going to further tank that program. But what are we going to do? Because their doors are not open anywhere else. So I think a look at the capacity is a good idea, but then I think you have to look behind why the capacity is what it is, especially if you have organizations, and we admittedly will do this, try and keep the program solvent. And the only way to do that is to keep it a certain size.
Dawn, that was similar to what I was trying to make the point around, is that I think that the demand is much higher than what the current enrollment in programs show. And so I don't know how you estimate or get some kind of quantifiable number. But I think even if we get any numbers that are accurate and usable are good data points, right? And we should get those. And then maybe there's an estimator or something that we could then further develop, which would, sort of like the Meals on Wheels program, right? Until the pandemic hit, we had no idea what the demand really truly was, and that really exposed a lot of the demand, for example, for that program, and it hasn't really ever gone down to pre-pandemic levels. So sometimes an event like what happened in Lewiston, it exposes the need even more.
Yeah, I think definitely we would want to look at wait lists. Understanding, I mean, obviously this is, I'm already going into the weeds, but understanding it's different for every organization. So we don't have a wait list for Section 19, and we'll never have a wait list, but we have our unserved hours. There's no wait lists to get into a nursing home. There's just a percentage of occupancy. So they go by occupancy rate, right? So occupancy rates, when I first started this work, like almost 14 years ago, it was kind of crazy. I remember Rick Err being really concerned that it was like 96 and 92% occupancy of assisted living in nursing homes. And he was sort of saying, hey, look, if home care collapses, we don't have any room for people. After the pandemic, it completely shifted, and it's in their 70s, and 80s, and was starting to go down. And so it's apples to oranges to pears to strawberries in some cases, in terms of the wait list for services. But Dawn, you're exactly right. Home care would say exactly the same thing if we had a home care person here. They have as many people as they can serve, and they don't maintain wait lists. There's no wait lists for home care. People call and they say, sorry, we don't have a worker for you. And that's so that the person calls the next entity. And I'm not talking about Maine Care. I'm just talking about average person on the street, trying to get services, because they can't add one more worker. They can't take on enough to add. It's a very convoluted and complicated situation. You're talking about Maine Care mostly. I'm talking about, like out there in just the real world, like, it doesn't matter if you could pay, you can't find a worker because the model is like tight. It's like, we're serving the people we can serve. We can't serve anymore. Too bad.
And I can attest to that.
Yeah, it's terrible. I mean, it's terrible out there. Mary Jane wanted to offer you an opportunity to offer your thoughts.
Thank you. I was sitting here nodding my head. I know you can't see me, but I'm in the car. So, when you were speaking before about how do we quantify the number of staff we need, well, some of that has shifted just by closing facilities, so that alone has decreased the availability of those beds, and yet we still are on average 82 to 85% of occupancy. 82% of our beds are filled. We can't go any further because we don't have the staff, and we could get the staff, but it's going to cost 3 times as much. So we start to balance, where's that tipping point where it just doesn't make any sense. And it's not just, we want to serve more people, but we can't. And we have regulations that prohibit us from, and in some cases rightfully so, but they prohibit us from taking more than we can staff for. So I guess my point is, if we're just looking at data of how many beds are not being filled because of workers, it's not a real true picture, because so many places have closed or converted, and more are to come. you know, we don't really know the true need.
No, absolutely. I think we will have to draft this specifically enough, but broadly enough so that we can have flexibility in the model that's developed to be able to try to get at the core question of what's a real care gap, right? I mean, what we're talking about is that people can't access care because of a workforce shortage, because there are no workers to deliver the care. And so that there is a gap in, and we would be talking at this point only about Maine Care and not more broadly. I think the broader conversation is much more difficult. But it starts to get at like, what is the magnitude of the problem? I mean, I have said this all along, right? The report that MECEP Maine Center for Economic Policy just put out, you know, which is indicating that we're losing over $1 billion in GDP a year because of this workforce shortage. You know, I have said, well, so if you even believe that, if you can believe that, even if it costs $500 million, right, to solve this workforce shortage, to attract more workers, pay a competitive wage for these workers, attract more workers into the workforce, you still have a $500 million return on investment. Right. So like we don't even know, is it 5 million? Is it 50 million? Is it 500 million? Is it $5 billion, right? That's going to solve this, but we don't know because we don't know if we need to hire 500 workers, you know, 5,000 workers or 10,000 workers into these jobs to fill the care gap. We just don't understand the problem.
Sorry, one of the other things I wanted to mention too is most of our hospitals throughout the state of Maine are caring for people that they really shouldn't be. It's just inefficient, you know. But the hospitals can't discharge them, one, because there's maybe not capacity in the nursing homes, but also there are people that really shouldn't even be in a nursing home. You know, they have mental health needs, they have, and not that we can't serve some people with mental health, but you know, they're young, they just don't need to be in a nursing home. But so they're being cared for, you know, they're in a hospital, and the hospital's taking that hit, but it's not very efficient. We could use you know, we could use some of the care that, you know, the providers that they have, we could use them in the other settings, and that would help, you know, shift some of it. But
great. Gloria, thoughts?
So do you want me to just share out like kind of for vocational, so career technical education concerns, issues that we see here? We have
actually, if we could just stick on this point about whether, so as part of this committee, would you be on board recommending that we pursue Maine Health Data Organization and collecting this data? And then we'll go back to updates.
Yeah, I think it would be helpful. Yes.
Great. Kim?
Yeah, I mean, I'm lucky I'm not the holder of the data, so I can promise DHHS for anything. I guess I have some questions, and I totally get the intent. Like, we got to know what the need is to know what the workforce is. I get that, and then I have to ask, because it's my world. Where are we going to get the workers from? So I think that there's a lot of issues that this committee is going to need to be trying to address, and if this is the first step, then I'm behind it. That's what everybody thinks.
Yeah, this isn't even ultimately about workers. It's about the care gap, right? It is the number of workers we would need, but not even, it's looking at how do we establish a baseline. I think we can all agree, if it's 10,000 workers, where are we going to find workers, right? But it means we have to shift workers who are in one industry and move them into another, and that's not very popular. I get that, but it's still, you know, we have to make a moral decision as a society. That's what we do, right? Collectively, as we make decisions about whether or not we're going to care for people, and if we're going to care for people, then and we say we're going to care for them, then theoretically we should care for them. So there's this piece of, we know that we have a significant care gap. The federal government is focused on this as well. We don't know how to define that, and it directly relates to our workforce shortage. Next step is, how do we get the workers into these jobs? And that's going to be the much tougher piece, right? And that's going to be a 10-year probably initiative, but you have to know what that number is, and you need to start figuring out, how do we measure whether or not. And so we started our conversation as a committee looking at, is there any way for us to figure out even the number of workers who are currently in this, and whether we could create a baseline number of workers from which we could measure, okay, there were 1,000 this year, there are 1,500 next year. We made progress, right? We got nothing. We're like flatline on that. So we've flipped and said, all right, well, we can't figure out how many workers there are and whether we're making any progress. So let's look at the care gap and see if everything we do, is it starting to shrink the care gap, right? So, I mean, if we can figure out how to measure one component of this and then see every year, are we making any progress to fixing the problem? And that's, what this little committee is supposed to be doing, is to see, are we making progress on the stuff we're doing? It's all good stuff. Like, nobody's doing bad things. Everybody's doing good things and trying really hard, but are we making progress?
And correct me if I'm wrong, Jess, but I feel like in previous meetings and other circles we've talked about this, you've also not only talked about the number of employees, but number sort of hours of service is another way to look at this, right? Like, I'm thinking of my sector, for example, Kim, it's like I have 85 direct care workforce, of which 100% of them are not 40 hours. So is there a way, like I said, can they do 10 more hours a week? Whatever. I mean, some of that capacity is not necessarily bringing on more people, but is there a way in which this workforce could work more to serve the people as well? So I think that's another way that we could tap into. And some is the benefits clarified, they can't take on more because they feel they're going to lose more. But is there a way that we can tap into that current workforce? Because I can tell you, probably of those 85, we have our sort of fiscal model to make this work. They should be serving at least 6 consumers a week, 6 people a week. That's 12 hours of work. I have 20 staff that are meeting that. The other 65 are working 2, 3, 4 hours a week. So there's a lot of room to grow there, right, in terms of capacity. And why is that, and where do we help that grow? I mean, we're offering full-time work. We will give them their 6 weeks paid vacation. We will pay for their medical. We will give them 401k. This is not moving the needle, right? So we've got this workforce that will not even jump from I'm doing 12, doing 6 people a week to I could take on 14 or 18 people a week and be a full ride. That's not moving the needle. But there is room there from a workforce standpoint to grow. So that's just an example.
Great. Okay, so I hear no one opposed. And so we will move forward in drafting this up. I wasn't going to do any work until I talked to y'all. So we'll draft something and shop it around and make sure people feel good with that. And Karen Lee, if it makes some sense, we can have a conversation with the department. Again, we don't want this to be in any way, shape, or form a negative thing. It really is intended to help everybody understand what baseline is. And we can take the next step after that. Does that make some sense? Great. So let's thank you, Karen Lee. And if you need to go, goodbye. Thank you so much for being here for the whole time. Appreciate it. So let's move back to updates. And Gloria, I'll go back to you since you were ready, if you're still there. But maybe she stepped away. Well, maybe she has stepped away. No, there you are.
Okay.
Good, go.
Yes. So, just earlier on listening to the updates that were happening, and something that's wonderful that's happening at Westbrook Regional Vocational Center is one of our challenges, like we're talking about credentialing for people to get licenses and to get out into the workforce. we have issues with our students getting graduation credits to attend here because there's a barrier with them not getting core content credit. They only are getting elective credits. And they come here for over 2 hours a day, 5 days a week, and it just isn't equitable. And the curriculum and the information in the work-based learning that they do is at a very rigorous and high level. Most of them it's at post-secondary level. We offer 9 of our 15 programs are dual enrollment programs. We have one program, advanced placement, and we have all of them have some kind of licensure or certification. And so something that's happening to help remove those barriers to get our students here so that they can graduate and either go on and further their learning at a college, university, or in a trade school, or they're going to be certified and ready to go into the workforce. And so I just wanted to share that we've made huge gains. I wrote a grant last year and created a committee here, and we've gone into the curriculum, shared this all out with our superintendents, counselors, and included teachers, department heads, and they're seeing that we have rigorous learning happening. And now we're at a place where we have several districts signed on to accept English credit, math credit, and science credit for the work our students are doing. So this is going to open up more doors, get more students into our school so that they can help fill this gap that we have. And I also wanted to say that through our advisory committees and just from all the people that reach out to me on a regular basis, looking for our students to work for them, for sure, our medical occupation students are sought after greatly for all of the care that isn't so needed. And so our students do get their CNA their second year when they're with us, so they're able to walk out and have that. So they're doing CNA work while they go to college, if some of them choose to do that, or going right into the workforce. So that's something to be proud of. I'm very proud of our school for the work that they have done to remove this barrier and get equitable credits for our students. And there's also LD 426 was passed saying that by 2025, high schools need to accept credits and give content credit where credit is due. And so things are changing. We're trying to remove the stereotypical stigma that has been, kind of shadowing career and technical learning for so long. So it's changing and we're excited about it, but it's, just like anything, it's slow and painful sometimes. So that's the update here.
Great. Other folks have updates they want to share? Go ahead, Kim.
Thanks. All right, so I usually update this committee on some of our healthcare training for me related work, so our tuition remission and our healthcare navigator. So happy to provide that update today. And if there's ever anything that you would like me to talk about, would like me to update you on, please feel free. Just let me know and I'll gather some information for you. But as of November 30th this year, healthcare navigators have received a total of 1,493 referrals through lots of different sources. So Healthcare Training for Me website is one of our primary sources. Of course, Caring for Me, that marketing campaign, our career centers, all staff there, and lots of community partners. So that's a large number. And my first caveat, I'm full of caveats today apparently, is that not everybody responded to our outreach. So they say, hey, I need something, or I want something, or information about something. Not everybody follows up. And there's a certain amount of spam that comes across the internet. So that said, the total number of individuals that we have engaged with or in conversations with is it's actually more than 700. So these are individuals who might talk with us once, or they might talk with us lots of times. And there's no real requirement. There's not really a program for them to let us know how things shake out, but they often do. So I can tell you that we know that 140 of these folks were connected to training opportunities, 168 individuals to supportive services, and 133 directly to employment. And the top 3 jobs obtained were CNA, home health aide, and certified residential medication aide. So doing a little bit of work over there. Then, of course, we switched to the tuition remission side. So as of November 30th, tuition remission has enrolled 713 individuals, and 284 of those have completed their training. So relevant to this committee, some of the certificates that have been funded include 348 individuals with certificates in mental health rehabilitation technology, MHRTC, ACRE training certification, CNA, personal support specialist, CRMA. I'll use an acronym that you don't know. I can't imagine with this group, but if I do, let me know. Registered behavior technician, certified alcohol and drug counselor, cool foot care nurse specialist. That was a really cool one. LPN, and finally, my passion, certified dementia care. So currently, of course, the caveat, if you didn't hear behavioral health professional or DSP, there's a reason for that. Those are fully funded by DHHS right now, so we don't have to supplement or support those. So we have about 1.5 years remaining for that particular project. We are about halfway to our goal, and we still have funding available. So if there are employers out there or individuals who are interested in gaining credentials, we're focused on folks who are currently in patient-facing roles across lots of different healthcare occupations, and moving up into a specialty or a next step in the career pathway. We do still have funds available. And those requests, of course, can come through Healthcare Training for Me, that website that I keep sharing, and I'll put it in the chat again. But if there are any employers that could use some help upskilling their workforce, we are here to receive them, and we have money to spend. Thank you.
Thank you. I was listening the whole time, was trying to deal with a very loud barking dog.
I have one under my desk. I understand. She was attacking me at the beginning of the meeting. I get it.
Yeah. All right. Other updates. Okay, hearing none, then we will move back to our participants. If anybody has comments related to the content of the conversation of the last hour, please raise your hand and Angelina will move you into our meeting.
I'm not seeing anyone. This crew has stuck around for a long time, though, the core group. So if you want to unmute, if you want to come off, I'm waiting for a hand raises. I got none.
Great. All right, well then I will give us all 15 minutes back because I think 3 hours is awfully long for a meeting. But thank you for hanging out with us, and good work today. I think we all learned a lot. So it feels like we're starting to move the needle just a little bit on the work. All right, and Catherine says maybe we need a break in the future. Maybe, yeah. Sounds good. All right. Thank you all very much. Have a great day and please have a happy holidays. Yeah.